Welcome to Seminars in HIV Care. Tonight, we focus on one of the most critical journeys in modern medicine, pediatric HIV care. From the challenges of the past to the breakthroughs shaping today and the possibilities defining our future. This session brings a full circle view of how far we've come and how far we can still go in protecting children from HIV. Thank you for joining us. Let's learn, reflect, and envision a healthier generation together.
Welcome, colleagues. Just to say, wow. Hey, I missed you guys. It's been how many weeks? Woo, we are back and it's 2026. This is our first official webinar. I know that we had the 10 days dream challenge, but that was New Year stuff, trying to challenge each other that in all of us there is always something great that God has put in our hearts and you should pursue it. But today, this is our first of the first webinars. And I can tell you, if you decided to join us this evening, you have made the right choice because this is the clinical care platform and it's all about you. We have a mission and we keep going at it, which is to transform the health system one health worker at a time. Why? Because we want to improve patient care, which is at the heart of what we do every day. And our way of achieving that is by helping you as a health worker to become better, to always remain updated, stay informed about changes in the environment. We want to help you to be very confident and to be competent, in how you manage our brothers, sisters, mothers, and fathers. And we just want you to always be ready. As a platform, yes, we do provide CPDs, it's a requirement, it's administrative. But if you do become a member of this platform, you will transcend the need for CPDs and focus on your transformation or the change that needs to happen for you to really live a life, of abundance, being able to care for your patients without thinking about that email that say, hey, you didn't comply. So yeah, it's such a great honor. And yeah, I'm not alone today. I'm with Dr. Christy Jackson. Let me see if I can switch around the technology here. Hi, Christy. Welcome. I know we didn't get to chat. I actually saw a very late message from you. I felt so bad. I was like, okay. But we will catch up. Are you well, Christy? Uh, why am I not able to hear you on my side? Let me just check if is it only me, because today my connections
Check
got.
now. Can
Oh
you?
yeah, that's better.
Okay.
Are you good?
No,
Welcome.
yeah, thanks. I was laughing now when you were motivating everyone to be their best, the best version of a clinician they can be so that we can treat our mothers, fathers, brothers, sisters. You didn't say our children, and we are here tonight to talk about the children.
No. I wanted you to be the one who addresses that. So yeah, thank you so much, colleagues. We are not going to waste a lot of time. Except for me to officially welcome you to the new year, to Clinical Care Platform, and today as well. Today's webinar we have great support from AbbVie. It's a webinar that we would have wanted to do last year as part of the closing, but we felt, we were a bit. It was a lot happening, so I'm happy that they were patient with us, to bring it to you today. And we are a platform. That means we thrive on partnerships and collaborations. So we really, really want to appreciate AbbVie for that. One other thing to note is that we are still a member-based platform. If you have joined us, you are not a member of this platform. It costs you 3 rands per day to enjoy the education, get CPD certificates, discounts, and many other things. It helps us to keep the platform going and to bring you some of the people who love teaching. We always talk about when expertise meets people who love teaching, you are going to be the beneficiary of that. So before I hand over to
I don't know if we lost Dr. Mawela. Can you still hear me? I can't hear him anymore.
after singing so many praises, Chris, I was like, Christy 5-star. Just imagine. All right, but just to summarize it, I was just saying I have a long history with Dr. Christie. We have worked together in Pumalanga, also at Right to Care, probably for a very short period of time as I was in transition. But we have managed to keep, contact since then. And I was just saying, please connect with her way of teaching, because she is going to be a regular here this year. Particularly, she is an HIV expert. We are looking forward to learn from her. She is part of the coaching team for our HIV diploma program, and also we are going to be establishing communities where you can post your cases when you struggle, and she's going to be one of our experts who will provide that support. So this is bigger than just this webinar. You can read the profile. She has done everything that needs to be done for her to earn, the language of an expert. Yeah. So at this point in time, I just want to hand over to you, Dr. Christie, as we are going to talk about HIV and the children. This is very, very important. If we had it our way, we would have 0 children living with HIV. But unfortunately, it still happens. And let us look at how things have been, where we are, and where we are heading. And hopefully, you can contribute to making that impact in this world. Dr. Christie, thank you so much. You can take us from here. Welcome.
Thank you so much. Okay, let me try and share my slides. Maybe just a word of, I don't know if it's a disclaimer or just a introduction as we are starting. Can you see my slides?
Yes. Thank you so much.
Something is looking funny here on my side.
It's probably my stuff. I'll switch it now. Just give it a second. Yeah. Okay.
Can you see my first slide there?
Yes, it's 100% on our side. Thank you.
Okay, perfect. Yeah, so just to say, I am not a pediatrician. I'm just someone who's been in the HIV program for about 10 years. I've not been in it right from the start. So when we talk about the past, some of it is what I learned from my colleagues and other people that have been in the program for longer. And also, it's not a high intensity training session tonight. We're not going to go into drugs and dosages and fine clinical management details. It's really more of a overview of where we came from so that we can understand where we are and where we need to go. Sort of at the start of the new year, let us get ourselves in that right mindset that we need to be in when we see our pediatric patients. Okay, so let's get started. So just a few words on the burden of pediatric HIV. How many children do we still have actually that are living with HIV globally and in South Africa? So there's still a lot of children becoming HIV infected. In 2024, it was estimated that about 120,000 children globally got HIV, and about 6,600 of them were in South Africa. These are obviously estimates, and if you look at different sources, different documents will have different numbers, but this was one of the official South African sources. Globally, there's estimated to be 1.4 million children living with HIV at the moment. That's children less than 15 years. And the vast majority of them are in sub-Saharan Africa. In South Africa, it was estimated that we had just over about 200,000 children living with HIV in 2023. And then globally, it was estimated that only about 55% of children living with HIV were actually receiving antiretroviral treatment in 2024. And the number is actually not that different in South Africa. It was estimated that about 112,000 children were receiving ARVs in South Africa in 2023. Again, the numbers are different if you look at different sources, but it's quite sobering to see how far we are off the target. But that's sort of the numbers we are talking about if we talk about pediatric HIV. So the numbers have dropped a lot in recent years. We'll look at some of the stats a bit later on. But why does pediatric HIV still matter at the moment? Why do we still have separate lectures about pediatric HIV? So there's just a few things I wanted to point out. One is that children face unique challenges that's different from adult HIV. So one of it is that children have quite a high mortality if they don't have ARVs on board early on. In the early years of the pandemic, we saw that up to 50% of children would die before the age of 2 if they were not on ART. It progresses quickly and a lot of them die. That's different from adults. Most adults who get infected will not pass away within the first 2 years of being infected because their immune systems are a bit more robust. Children are so much more vulnerable. And children are biologically and developmentally different from adults. There's different psychosocial things that come into play with children, how they understand how their doses must be adjusted, all those sorts of things. If we look at our data, there's always gaps in the treatment cascade between children and adults. We struggle more with case finding, we struggle more with linkage to care compared to adults, we struggle more with treatment coverage and viral suppression. And it's not just a South African thing, it's globally we find these same trends. And the epidemic is not over yet. We want it to be over, but we are still finding new pediatric infections every year. We've made a lot of progress, but we've not reached the end of the road yet. And the other thing is our children that acquired perinatally, acquired HIV perinatally, they are growing up. They are now living with HIV and they need different sorts of services and support than just a normal adult patient. So what are the main objectives of this evening? Firstly, I want us to just remember where we came from. If we see where we came from and we remember where we were, we can really appreciate the progress that we have made to date. Then I want us to see where we are at the moment. What's the current status of the epidemic in South Africa and where are the gaps? Because if we don't look at our data, we don't know where the gaps are. so that we can see these gaps and identify our priorities for the future. Which activities do we need to focus more on to close those gaps? And then we'll end with discussing a few practical things that we can do, whether we are clinicians or program managers or policymakers, so that we can sustain the progress that we've made so far and that we can move towards the elimination of pediatric HIV in South Africa. So let's start with the past. How did we get where we are now? What did we go through before we got to this point? So in the early years of the pandemic, the maternal mother-to-child transmission rates were really quite high. Before we had effective PMTCT programs, remember we called it PMTCT then, we now call it VTP. But before we had these programs, it was estimated that between 25 and 40% of infants born to mothers living with HIV got HIV from their mothers, whether it was in utero or during the birth process or through breastfeeding. Before we had any interventions, this was the transmission rate. And that's so high. I mean, it's not 100%, right? But between a quarter and 40% of all children with positive mothers ended up HIV infected before we had interventions. Also, in the early years of the pandemic, the ART options were quite limited. The early ART regimens for mothers and for children, but it often involved monotherapy or dual therapy. Drugs were expensive, drugs were poorly tolerated. They didn't all have high efficacy levels, especially in children. And clinicians in South Africa often had to adapt adult formulations for pediatric use because we didn't have child-friendly formulations at the time. And another thing that we forget is that many clinicians back then were not yet trained on HIV management. I think we take it for granted now that so many of us are familiar with HIV management. But back in the day, it was only really specialists and doctors who were treating these patients. And then with time, we started doing task shifting and empowering nurses to also look at children and to HIV patients, and then specifically children as well. So the drugs were limited, and the knowledge for clinicians to actually treat the children with these drugs was also limited. Then we had high infant and child mortality as well. Because we didn't have effective treatment, the HIV infections in infants and young children rapidly progressed. I said that, almost 50% of children died before the age of 2. Untreated children often only survived about a year if they were not really treated. And during the peak of the epidemic, like the early 2000s thereabouts, AIDS was also a leading contributor to under 5 mortality in South Africa. At one point, they actually estimated that almost 40% of under 5 deaths were due to AIDS-related causes. And if you think of today, I mean, we've come a long way, but that was where we were in the early years. And then we can't forget the impact that all of this had on families. Because so many parents lost their lives, this resulted in large numbers of AIDS orphans. So these are children who lost one or both parents to HIV or AIDS-related causes. And a lot of the AIDS orphans in the world were actually in, I think about 90% were in sub-Saharan Africa, and thousands of them were in South Africa. And the other scary thing is, without the absence of effective ARVs, palliative care was often the only option for HIV-infected children. So the focus was less on disease control and more on symptom relief. And because our treatment options were so limited, these children often suffered from frequent opportunistic infections and poor quality of life. So for the positive children, the options were limited. For the uninfected children, even if the child was negative, they had often lost their parents. So it was really a sad period of time to be working in this space. But through hard work and dedication and step-by-step improvements, we have actually come a long way in South Africa. So I just want to highlight a few of the major policy milestones that we had in South Africa. Let's look at the evolution of maternal ART policies first. So South Africa's public sector VTP or PMTCT program actually started in 2002. Remember, general rollout of ART, the national program, only started in 2004. But in 2002, the PMTCT program started, and all it consisted of was basically single dose nevirapine at the onset of labor. So we would know these women had HIV. We would not give them anything throughout pregnancy, but when they went into labor, we gave them a stat dose of nevirapine. That dropped the viral load a little bit, got some nevirapine into the baby's body, almost like a pre-exposure prophylaxis to the baby that's going to be delivered, and that was all we had. It dropped infections a little bit, but obviously it was not nearly as effective as we wanted it to be. Then in 2004, we started having a general rollout, but it was only limited to people with a CD4 less than 200, right? From 2008, the VTP policy changed that we could give dual therapy to mothers, those that didn't qualify for ART. So with dual therapy, it means we gave them AZT from 28 weeks of gestation, and we gave them a single dose nevirapine when they went into labor. That was dual therapy. That was all they got, unless they qualified for triple ART. From 2010, we gave them triple ART if the CD4 was less than 350. Otherwise, we still gave them dual therapy if the CD4 was above 350. So that was called option A. And these options came from the WHO phrasing. So it was sort of adjusted in different countries. From, I think, 2013, we gave triple ART for all pregnant women, regardless of the CD4. But here's the catch. If the CD4 was above 350, we stopped the ART again after delivery or somewhere in the postpartum period. We didn't give them lifelong ART. We gave it to them, and then once the baby was out, we stopped the ART. That was 2013. And then only from 2015, that's 11 years ago, we started giving triple ART to all pregnant and breastfeeding mothers, and we continued them lifelong, regardless of their CD4. So there was a long period before this that the VTP program was not very strong. You can imagine why we have a lot of adolescents these days that are living with HIV, because when their mothers were pregnant with them, those were the options that were available: single therapies and dual therapies and stopping treatment again after delivery. So it's only really from 2015 onwards that mothers were eligible for immediate triple therapy and continuing it lifelong. So remember that when you see your adolescents and when you work with the mothers of your adolescents. You know, we are quick to blame mothers for children that become infected. She didn't go to the clinic. She didn't take her treatment. Maybe the treatment that was offered to her back in the day was the best we had, but in retrospect, it wasn't that great. Then let's recap what happened with our strategies for our infants. For the infants as well, initially our strategy was a single dose nevirapine after birth. And then later on, from option A onwards, which was around 2010, we extended the nevirapine to daily nevirapine infant prophylaxis, which was given for 4 to 6 weeks. We only started the dual infant prophylaxis later on. All these things we have now of high risk and low risk babies, and according to the mom's viral load, all of that came later. So even if the baby was in care, the prophylaxis we gave was, in retrospect, not necessarily that great. Also, PCR testing schedules have changed a lot. Initially, we only tested babies at 6 weeks of age. There was no birth PCRs. So that meant that babies who were actually already infected intrauterine, they didn't have a birth PCR, and many of them were already critically ill, or some of them had even passed away already by the time they would have been 6 weeks old. So many babies didn't even make it to their 6-week test. They passed away with HIV because we didn't know that they had HIV, because we didn't test them at birth. And that's why later on we changed to have 2 testing periods, both a birth PCR and a 10-week PCR. So the birth PCR catches those, not the ones that got infected during the delivery process. Remember, delivery is a high-risk exposure, right? There's blood, there's amniotic fluid, there's mucous membranes. But the birth PCR doesn't pick up the baby that got exposed and infected at the delivery process. It's too early. It's still the window period. The birth PCR picks those up that were already infected earlier in the pregnancy. So some babies will have a negative birth PCR, but at 10 weeks they become positive. So that might mean somewhere during the delivery or the early breastfeeding period there was a challenge. But the birth PCR was so crucial for us to pick up which babies were already infected, already living with HIV, so that we can quickly get them on ARVs and get them to survive into infancy and childhood. From 2019, we also started including the 6 months PCR testing because we realized there are more babies who get infected later on in breastfeeding. And then also we added the 18-month test. Initially, it was only for exposed children. And then later on, we expanded that to universal testing. That's where we are now. Then let's talk about how our cotrimoxazole guidelines have changed over the years. So in the early 2000s, there was a trial called the CHAP trial. It was done in several countries in Africa. And this showed that cotrimoxazole reduced morbidity and mortality in children living with HIV because it prevented some opportunistic infections and it treated some opportunistic infections. But basically it helped children with weakened immune systems. It was sort of a empiric treatment and prophylaxis for them. And because of the results from the CHAP trial, the WHO recommended that all HIV positive children should receive cotrimoxazole. And they also recommended that exposed children should get cotrimoxazole until HIV infection is excluded. So in South Africa, because our testing schedules were not that good yet, we knew that there were a lot of babies out there who might be living with HIV and that we are not picking up because we are not testing babies regularly, right? So that's why the guideline in South Africa used to be that we gave cotrimoxazole to all exposed children until they tested negative post-breastfeeding. So the whole breastfeeding period, we used to give them cotrimoxazole. On the off chance that they became HIV positive and we didn't test them, then at least they had cotrimoxazole on board, which helps protect them from opportunistic infections because they're now untreated. But our program has improved. Over the years, our our transmission rates dropped, so there were less positive children out there, and our testing schedules improved. So we picked them up a lot quicker. So we realized around about 2023 that now the risks of giving cotrimoxazole to all exposed children actually is starting to outweigh the benefits. There are so few children that will benefit from it if we just give it to everyone, but it actually has real risks. Remember, cotrimoxazole is an antibiotic. It can interfere with the gut microbiome. And a lot of research has been done in the last decade or so on the gut microbiome. So basically, the healthy bacteria in the gut. And exposure to cotrimoxazole can also lead to resistance, and that can cause cross-resistance to other antibiotics, including amoxil, which is one of our first-line pediatric antibiotics. So now, from 2023, we reserve cotrimoxazole for our children who are living with HIV. We give it to everyone under 1 year, and then after 1 year, we give it to those with lower CD4s or based on their clinical staging, basically. So that's why the cotrimoxazole guidelines have changed. And then we've also had a lot of formulation challenges and progress, luckily, in our pediatric ART regimens. In the early years, before ARVs was available in the public sector, some patients who were lucky enough to be able to afford ARVs in private were given regimens with drugs like adenosine and stavudine and ritonavir. These were not great regimens, but many children survived because of these regimens, despite its toxicities, despite its poor tolerability. And then from 2004, the national ART rollout began. And then we gave children stavudine and lamivudine. And it was combined either with lopinavir, ritonavir if they were under 3, or efavirenz if they were above 3. But initially, we didn't even use lopinavir for children less than 6 months because we didn't have data for that age group. So children under 6 months were given a full dose ritonavir without lopinavir, with stavudine and lamivudine. And of course, many children got resistance to protease inhibitors because of that. Then later on, stavudine was changed to abacavir, which is obviously a safer drug with less toxicities. And the other benefit was that we could then do once daily dosing, where stavudine was twice daily, abacavir is once daily, and that obviously helps improve adherence. But then we still had lopinavir syrup for our younger children, and that was also quite poorly tolerated. The babies managed a bit better, but especially the toddlers and the older children didn't like it at all because of the taste. It tasted quite terribly, and it was mostly given twice daily. So every morning and every evening, they had to take this really bad tasting syrup. And then even the ones who started a bit later, above 3 years, who were given efavirenz also caused problems. We didn't always know that, but many children struggle to concentrate in school due to the neuropsychiatric side effects of efavirenz. And if a child had been on efavirenz almost his whole life, it's difficult to know what parts of the child's personality and development is his own and what is actually a drug side effect. And the other thing is these children already missed some days of school because of clinic visits, because of illness, because of their HIV. And now giving them a drug that causes them problems with concentrating in school or staying awake in class, it just put them even further behind their classmates who were not living with HIV. So it was really quite a complicated situation that our children had when they had these drugs. Then in 2019, dolutegravir became available. Was it 2019 or 2020? I think it was 2020. We started getting dolutegravir. Initially, we had the 50 milligram tablets that we could use for children from 20 kilogram and upwards, and TLD initially we gave from 35 kilograms and 10 years. So our children less than 20 kilograms were still left behind on these poorer regimens. But we've changed that as well, so I'll mention our current regimens, which you're all familiar with, when we get to the next section when we talk about today. But this is just to give you an idea of where we came from and the milestones that we reached throughout the years as our program expanded and developed. What was the impact of all of this? You can imagine, you can imagine that with an improving program and better access and better drugs over the years, we saw a decline in mother-to-child transmission rates. We saw less children becoming infected with HIV. We saw an increase in ART coverage in children, and we saw decreased pediatric mortality rates. So I just found a few graphs to show you some nice, happy pictures. This slide shows the decreasing HIV prevalence in testing services. So this is children from 18 months to 4 years of age. You can see here in the 2007-8 thereabouts, it was almost 15% of children that were tested positive. And then later years, it came down a lot. So there were less children newly infected that were testing positive. Then if we look at the modeling, how many children we are estimating got newly infected with HIV in South Africa, this is also 0 to 14 years. We peaked in 2004 with about 80,000, 82,000 children estimated to have become newly infected in that year. Then after that, when we started giving proper treatment, mother-to-child transmission started dropping. You can see this nice steep decline here. 10 years later, in 2014, it was estimated that about 13,000 children got infected that year. And in 2024, oh, sorry, that's a typo, it should be 2024, it was estimated that about 6,600 children got infected. That's the number I showed you in the first slide there in the beginning. These other gray lines here are other African countries. This one here, I think, was Kenya. This one here is Mozambique. So Mozambique is above South Africa at the moment. But you can see South Africa peaked higher than any other African country. But we came down nicely. We just wanted to go down that last little bit to be close to zero. Total number of children on ARVs in South Africa, you can see when the program started, there was a steep incline as we found all our children, got them on treatment, or not all of them, but a large number of them. And then it started plateauing. The number is a little bit declining at the moment, partially because our children are aging out of the program. They are not falling in this bracket of 0 to 15 years anymore. They are now becoming older adolescents and they are counted in the adult program. When looking at the mortality, this is the total under 5 mortality rate in South Africa. You can see how it peaked as a result of AIDS-related deaths here in the early 2000s. And then after 2004, when proper ARVs became available, the mortality rate started dropping again. So it's quite nice to see, as bad as it was where we came from, a lot of work was done to improve the system, and we could see it in our results, in our data. So where are we at the moment? We have a lot of things. I'm sure you are familiar with a lot of these things. We have so many guidelines. We've got strategic plans. We've got alliances. We've got coalitions. We've got charts and job aids and goals and targets. And all these things, it's sometimes overwhelming how many things there are out there. But all of it tries to work on a part of the program to help improve our patients' lives, to find everybody, to get them on the best possible treatment and get them to be virally suppressed so that they can live long, healthy lives. This is our treatment cascade at the moment. I'm sure you've all seen these slides. It's a couple years old now, but it's some of our official South African stats. The one on the left is the total population. It's the 95-95 cascade. And then on the right is children less than 15 years. You can see where we are with our adults. We are on 95% for our case-finding, people who know their status, and 92% are virally suppressed. It's not looking too badly here. Look at our children. Look how they compare. We are estimating that we have just over 200,000 children living with HIV. We have about 169,000 of them that know their status. That's 82%. Of these, only 112,000 are on treatment. That's 66% of these, not of the total, of the ones who know their status. Then we have about 83,000 viral loads done every year in these kids out of the 112 that are on treatment. That's 74%. And then only 67 of these are suppressed. And this is suppression to less than 1,000, not even less than 50. But look, if you compare how many children are virologically suppressed, 56,000, compared to how many children are estimated to be living with HIV in South Africa. That's quite a big difference, eh? I mean, the adults also has a difference. It's a much smaller difference compared to the children. So our children really are lagging behind, and we need to, even though there are so many less children than adults, we really need to go the extra mile to find them, get them in care, and get them to be suppressed. I'm sure you've all seen this as well. There's a WHO program for elimination of vertical transmission of HIV, where they monitor different countries on the BTP programs, and then they give them certificates, whether they are bronze, silver, gold, or full validation. And there's different criteria that they have to achieve. The rate of antenatal care coverage, the rate of women on ART, the new pediatric infections, all of that. And then you have to sustain it for a while. As far as I know, South Africa is still on bronze. I think we are aiming for silver. Somebody can help me if I missed something, but I don't think we have achieved silver yet. I think Botswana has silver. I think, and Namibia. There are a few countries in Africa already progressing, but I don't think many countries have reached full validation of elimination, but that's what we are aiming for. So what are our program strengths in South Africa? We have a lot of good things going. In the VTP program for the mom, we've got very good maternal coverage with dolutegravir-based regimens. A few years ago, we went through that whole switch. We all attended lots of trainings on knowing which mothers or which patients are eligible for switching to DTG-based regimens. Now we've done that. It's almost surprising to find someone who is not on a dolutegravir-based regimen. So that's really great. We are doing better with our maternal EGK codes. I hope you're all familiar with them. That's those codes that you put on the lab form when you collect blood from a pregnant or breastfeeding woman, which helps us to then track which of our unsuppressed viral loads belong to pregnant and breastfeeding women so that we can prioritize their care. And we've improved our viral load monitoring and our viral suppression rates in our pregnant mothers. We are doing our delivery viral loads. We are doing viral loads at baseline booking for those who already know their status. And we've improved with this over the last few years. On the child side of the VTP program, like I said, we've extended our testing schedule. We are now even including the universal test at 18 months for every single child, whether they are known to be exposed or not. We are finding quite a lot of children that way. We are encouraging clinicians to test all sick children, all hospitalized sick children. We are doing index testing as well, so we are improving with this. Our infant prophylaxis has improved a lot. Now we've got high risk and low risk. We've got nevirapine, we've got AZT. We can extend our nevirapine as long as the mom is breastfeeding with an unsuppressed viral load. We will continue giving nevirapine while we try to get the mom to be suppressed. We are basing our choice on whether the baby is high risk or low risk on the mom's latest viral load. And this has really helped a lot. And we also have the PCR results for action reports. So if any of these children do test positive, it helps us to find them quicker so that we minimize the delay to treatment initiation. We've also come a long way with new drugs and formulations. We've now got dispersible pediatric dolutegravir, that 10 milligram tablet, which we can give to all our kiddies from 3 kilograms, as long as they are above 3 kilograms and above 4 weeks of life. They can get the dispersible pediatric dolutegravir that is available in almost all our facilities. And now we've got, instead of all the syrups that we used to have, we've now got dispersible ABC3TC tablets as well. And we also have ALD fixed combination tablets for the older children. So our pediatric regimens, and many of them, they don't taste bad anymore. I'm sure you all know they have this sort of strawberry flavor, like a strawberry milkshake, some of them. So the children actually like taking their treatment instead of fighting against it. And it's all once daily, so that's a bonus. And we've also got a lot of community models for case management. We've got our ward-based primary healthcare outreach teams in many areas. We've got mentor mothers in some places. We've got different community-based organizations. And our children can benefit from some of these community systems that we have in place. So we've got strengths, but we also have persistent challenges. Some children are still being missed for testing. If we don't know what the child's exposure is, or if we don't pay attention to their risk factors, we will miss the fact that we should test them. That child who comes with minor ailments over and over again, have we tested that child? Maybe the mom says she's negative. Maybe the mom is really negative. Maybe the granny is bringing the child and we don't know what the mom's status is. Let's test our children not only on the set time periods that we should test them, like birth and 10 weeks and 6 months, but also when we have a clinical suspicion, or when a parent is newly diagnosed, or when a sibling is newly diagnosed. Let's test our children and not miss anyone. We also have children who are lost from care. Sometimes it's due to logistical challenges, transport challenges. Maybe the family is moving around. We've got mobile populations. Sometimes we've got situations where maybe a mom used to bring the child to the clinic, and now the child is living with the granny. And the granny doesn't even know that the child used to attend the clinic for their ARVs. The granny doesn't even know the child's status. So she doesn't know that she's supposed to bring the child to the clinic for ARVs. And then the child becomes lost from care. We also have advanced HIV disease in some children and some adolescents. Sometimes it's because they are missed for diagnosis, so their disease progresses quite far before we eventually diagnose them. And other times, children have adherence challenges. They get tired of the pill burden, or maybe they are not disclosed to, they don't understand why they should take their treatment, and they stop taking their treatment. Sometimes they stop completely, sometimes they take it, some days, and other days they skip, and they end up with high viral loads and low CD4s and opportunistic infections. And when they start getting things like TB, if they get repeated TB infections, then they sit with bronchiectasis, complications like that, permanent lung damage that they have to live with the rest of their life. I've mentioned the viral loads. I mean, it comes with the same issues of poor adherence, different reasons contributing to that. Then when it comes to drug resistance, there's a few things that's different in children than with adults. The one is because children are more likely to be on abacavir-based regimens than tenofovir-based regimens, our younger children. Abacavir is actually a slightly less robust drug than tenofovir. Otherwise, we would have just given everybody abacavir, right? Because it's better on the kidneys and the bones and everything. But tenofovir is a bit more robust. So children, especially if they are on a second-line regimen with dolutegravir and abacavir and lamivudine, your chance of getting resistance is slightly higher compared to if you're on a tenofovir-based regimen. And the other thing is, because many of our children were on lopinavir-based regimens as babies, we switched them to dolutegravir-based regimens now because they were suppressing. But lopinavir was also quite a potent drug if you adhered to it and you took it very well. And it's possible that during an earlier period of poor adherence, they might have picked up some resistance mutations to abacavir and lamivudine, but the lopinavir was still strong and susceptible. So when they started adhering well, again, the viral load suppressed fully. But then we changed them to a regimen with DTG, ABC, and 3TC. And then they might actually pick up more resistance because of that pre-existing mutations of the NRTIs. So it's a bit complex, but just keep in mind resistance patterns is a bit different in children who had vertically transmitted HIV compared to adults. And then obviously our social and structural areas are always persistent challenges, whether it's socioeconomic status, complicated families, stigma, all those sorts of things. We still have to deal with all of that. I hope I didn't depress you. I hope I painted a picture of where we came from, where we are now, and now we need to look at the future. Where do we need to go from here? So let's look at the VTP cascade first, because obviously we have to start with the mom if we want to protect the babies. We have to improve maternal viral suppression. As much as we have improved it over the years, if we compare viral suppression in the general population to viral suppression in pregnant and breastfeeding women, and we can see that using the EGK codes, viral suppression is lower in pregnant and breastfeeding women compared to the general population by a few percentage points. And if we can choose one subpopulation that we really, really want to be suppressed, it would be our pregnant and breastfeeding women. So we still have to close the gap a little bit on this one. We can also strengthen our digital tools. We are in the digital era now. We've got AI things, we've got nice apps. We can use Mom Connect. We can use facility dashboards with our data to make sure everybody is on board, everybody has the information they need to do their jobs. We can strengthen community tracing and family testing. If we know one family member is living with HIV, let's test the entire family, all the siblings, all the children living in that family. Let's make sure we strengthen the follow-up of high-risk infants so that we make sure they get the prophylaxis they need for the right duration. We make sure they get tested again, and we don't miss any of our high-risk babies who might either need to continue their prophylaxis or might have tested positive and need to be initiated as soon as possible. And let's not forget our family planning strategies. Our newly diagnosed patients, women, and virally unsuppressed women, we really don't want them to fall pregnant unless they are virally suppressed. We want to help our mothers to plan their families at a time when it's suitable to them, but also when they are healthy and when it's medically a good idea for them to fall pregnant. So make sure you offer family planning for all your newly diagnosed patients and all your unsuppressed women. Let's help them to plan their pregnancies for a later time when they are virally suppressed. You know, that's the start of the VTP cascade, making sure we don't have unintended pregnancies in women with unsuppressed viral loads. And then we also shouldn't forget our HIV negative women. I'm moving backwards in the process, right? Our HIV negative women, we should be giving them PrEP. We are seeing so many babies these days who are unexposed at the time of delivery, and before they reach 18 months, they are part of our ART cohort. How does that happen? The mom is breastfeeding, the mom is now sexually active again, the mom gets infected in the postpartum period while she's breastfeeding, she spikes her viral load due to a new infection, and the baby becomes infected with HIV. So let's give PrEP in pregnancy, but let's not forget to continue PrEP in the breastfeeding period so that we protect all our babies as much as possible. Then I want to look at a few innovations, some of the exciting new clinical and programmatic things that we might be looking forward to, some sooner and some a bit longer down the line. The first very exciting thing is our long-acting PrEP, our lenacapavir. This is coming soon. This is one of the most exciting things for 2026. National Department of Health is already busy doing master trainings in some of the provinces. We've already selected some facilities as pilot sites, and within the next few months, our pilot sites are expected to start providing lenacapavir as PrEP. It will be for all adults and adolescents who are above 35 kilograms who test negative for HIV. It will be subcutaneous injections. They will get 2 small little injections every 6 months. The first time when they start, they will also get 2 tablets on that first day and 2 tablets that they take the next day. Then it's the end of the tablets. After that, they only come for their 2 little subcutaneous injections twice a year. How brilliant will this be? We can keep our adolescent girls negative, and we can keep our mothers negative so that they don't transmit HIV to their babies. So this is really one of the big progress steps that we have taken recently, and we are all looking forward to this very much. Then we also have long-acting ART options possibly for adolescents. This is not as close as the lenacapavir PrEP, unfortunately. So the long-acting ones that we will have this year is for PrEP. Long-acting ART is still in the pipeline. It's available in some other countries, but it's quite expensive. In the South African program, it's not really one of the things that we are bringing in very soon. But it's good to know what's out there. It might still be coming in future years. So there's things like carbotegravir and rilpivirine that can be given as injections. My understanding is that if you give these 2 together, you can give the injection every 2 months. So instead of taking daily ARVs, you just come for your injection every 2 months. There are studies looking at combining it with lenacapavir, and then you get all of them every 6 months. There's also oral long-acting treatment. For example, if you combine lenacapavir with islatravir, there are studies looking at once a week tablet dosing. And this is for treating HIV. So instead of taking your TLD 1 tablet once a day, you might only take your tablets once a week or come for an injection every few months. So not coming to us anytime soon, but it's good to know it's out there. Studies are ongoing, and it is something we can look forward to a bit further down the line in the future. What about point of care viral load and CD4 testing? I also don't think it is something that is immediately on the way in South Africa. It's actually more prevalent in some countries, like more rural countries where they have poor laboratory access. But it would actually be such a great thing that we could have in South Africa. Because if you could do a point of care viral load or a point of care CD4 with an immediate result, maybe it takes a few minutes or an hour or so, you can give the patient appropriate counseling and appropriate support. You can make better clinical decisions. You can decide quickly whether you must start cotrimoxazole for a low CD4 or stop cotrimoxazole for a high CD4. And you need less follow-up appointments. You don't need to call somebody back to say, I saw your viral load was high, now I need to do adherence counseling. You can do it immediately on the spot. So how great would that be if we can get this also available in some of our facilities? Then I want to mention some of the new formulations. We already have nice pediatric drugs, but it's getting even better. Some of them are already available in the private sector. Some of our provinces are doing buyouts, but it's not in our ART guidelines yet. Hopefully, when the guidelines are updated, these drugs will also be on tender and will be available. So we've got TAF, tenofovir alafenamide, which is a cousin of TDF, but it's a bit more renal friendly and bone friendly. So we can give it from a lower weight compared to TLD. So some of our younger children will also benefit from this. It's a bit more robust than abacavir. This will be a drug with a dual purpose. It will be for some of our younger children before they qualify for TLD, but it can also be a perfect drug for our adult patients with renal impairment and hepatitis B positive, where we still want to include tenofovir. We want to give something that's a bit more renal friendly. So some of our adults will also benefit from this, but definitely also some of our children, not the babies, but some of our slightly older children. And then we also have a fixed combination of EALD. So it will be 30 milligrams of abacavir, 60 milligrams of abacavir, 30 milligrams lamivudine, and 5 milligrams dolutegravir. One tablet with all of this in, and it's dispersible. So we'll put all the tablets in the glass. You just count how many tablets to give based on the weight, put it in the glass with a little bit of water. The child takes it, and they've got all their treatment. So the mom goes home with one bottle instead of multiple different bottles and multiple different tablets she has to count. So that will also be a very nice drug to have for our babies. Then I wanted to mention as well integrating HIV care with all our other allied programs, nutrition and mental health. There are so many different things that we need to include in our holistic care, our multidisciplinary teams. It's not really an innovation as such. I mean, it's been around, but we really need to upscale that. Make sure that we check our nutrition status, check their weight and height and everything that we should check, their MUAC, make use of psychologists and social workers where necessary, make use of pediatric support groups where you can be able to create them, community outreach workers, peer supporters. We have so many people out there in the community who are able to do home visits and support families, and then upscale to psychologists and psychiatrists if there are more complicated cases. Don't try to treat the patient by yourself. Children often have complex situations, and we need all team members to play a role. Staying on the point of adolescence, make sure we've got youth-friendly services in our facilities. Make use of peer navigators where possible. Remember that when children transition from pediatric to adult care, where we are in facilities where there are different streams, that can be a bit of an adjustment for them. So help them through that. And then disclosure as well. I didn't say much about disclosure in this presentation, but even if disclosure was done, children and adolescents still need post-disclosure support. They might need some things to be repeated. They might have further challenges and questions later down the line. Then I just wanted to mention the advanced HIV disease guidelines. They are hopefully coming out soon as well. It's another thing I'm looking forward to this year. So this will be for all ages, not just for children. But I just wanted to remind ourselves of the definition of advanced HIV disease. So for children and adolescents 5 years and above, it will be a CD4 below 200 or stage 3 and 4. All children living with HIV younger than 5 years are considered as having advanced HIV disease, regardless of the CD4 or the clinical stage, unless been on ART for more than a year, and they are clinically stable and vitally suppressed, and they are not. So there's actually a lot of our children that will qualify as advanced HIV disease, and the new guideline will have a lot of interesting information on how to manage them, how to screen them, how to treat them, to make sure we care for them properly. So look out for those guidelines as well coming soon. Then what are we aiming for? We've got some very ambitious targets. I'm sure you all know the 95-95 targets from UNAIDS. And if you saw that graph that I showed earlier, we are quite far away from 95 by 2030. Now it's already 2026. We say we want to end HIV in children by 2030. That's what the Global Alliance is saying. Can we do that? Is it still possible? Or how close can we get? So what would success look like? What key milestones can we aim for to try and get that? There are a few things I want to point out. One is universal early infant diagnosis. If we can give all HIV-exposed infants a PCR test at birth and the follow-up tests at the correct periods, we will have minimal missed or delayed diagnoses. We want no child left behind with ARVs. We want all children who are diagnosed to immediately be started on ARVs. We want more than 95% of our children to be on treatment, including those hard-to-reach communities. Think the rural children, think children of key populations, children of mobile families. All of them need to be on treatment. And all of them, we want them to be suppressed. At least 95% of them should be suppressed. We want to support our adolescents with adolescent-friendly services until they can transition to adult care. We want our children to have healthy childhoods and futures. We want our children to have normal growth and development despite living with HIV. We want them to have healthy and productive lives with minimal HIV-related morbidity. And we want zero stigma. We want to support social support or to strengthen social support so that children can be supported where they are and not be stigmatized for living with HIV. And if we can do this, it will translate to having less new infections, less hospitalizations, and we can have children that not just survive, but that thrive into adulthood and can be good, productive members of our communities. So what are the key takeaways from this? If we've now seen where we came from, where we are, and what can possibly lie ahead for us in the future. One thing I want us to remember from this is that South Africa has made extraordinary progress from where we started in the 90s and the early 2000s. South Africa's pediatric HIV program is now one of the largest and most impactful in the world. And over the last 20 years or so, new pediatric infections have drastically fallen. Pediatric HIV deaths or AIDS-related deaths have dropped drastically as well. We now have universal VTP, we've got expanded ART coverage, we've got birth and early infant PCR testing, our improved drug regimens. All these things have transformed the outcomes of our children, and children who would have died in infancy are now living and thriving into adolescence and into childhood. But we still have gaps. And the gaps that we have are solvable if we have the right urgency and if we make the right commitments as a country. Things like missed diagnoses, things like late PCR testing, delays in linkage to ART is programmatic issues. It's not inevitable. We can put systems in place to try to prevent those things. Problems like poor viral suppression, poor retention in care in adolescents. We can solve those problems if we involve all our multidisciplinary team members and we get the right psychosocial support on board. Things like stigma and social barriers like transport problems and caregiver instability, children who are orphans and are cared for by other aging family members, it will remain challenges, but we can address some of these challenges with integrated community engaging programs. So the barriers that are remaining are not really biological, they are systematic problems. It's things that we can fix with our program and with our policies. And then if we innovate where necessary and we strengthen the basics, we can achieve elimination. So with innovation, I'm thinking of things like point of care testing, point of care viral loads and CD4s, child-friendly, long-acting art formulations, using our data to track our HIV-exposed infants, differentiated care models for adolescents, those sorts of things. And then strengthening the basics. I'm thinking of things like timely PCR testing, making sure we have a results management system in our facilities, that we don't miss that result. We can trace the child immediately. Immediate ART initiation for every positive child, making sure we do the viral loads when they are supposed to be done. Make sure we respond to non-suppression. Our guidelines are in place. We just need to do the basics. Make sure we support the caregivers as well. Adherence counseling to caregivers, adherence counseling to older children, disclosure at the right time, the right psychosocial care that we are supposed to provide to these families. We don't need a perfect system. It would be great, but we'll never have a perfect system. But we need to do well with the basics. We need to consistently do the basics and then have thoughtful, fresh, innovative ideas where necessary. So what can I do in my environment? What can you do in your clinic, your hospital, your pharmacy, your office, wherever you find yourself? Clinicians, we need to champion early diagnosis and immediate ART initiation for every child. We need to prioritize viral suppression. We need to prioritize adherence support on the right level based on the child's age. We need to encourage disclosure. We need to advocate for youth-friendly services. I'm just mentioning a few things. I'm sure you can all think of more things that you can do as clinicians where you find yourself. Program managers, we need to use data to find where children are being missed, which age groups are being missed. Is it boys? Is it girls? Is it the older ones, the younger ones? Which geographical areas are they that we need to upscale testing? We need to strengthen our early infant diagnosis, follow-up and linkage systems. We've got the PCR results for action. What do we do with those reports? How do we use that as program managers to support the facilities? And how do we build bridges between facility care and community care? That's for program managers to deal with. Then we've got policymakers, the people who write the guidelines, the people who do the procurements. They need to invest in child-friendly formulations. They need to think of long-acting ART for certain adolescents who will really benefit from it, even if it's expensive. We need to support things like point-of-care diagnostics. Our policymakers must ensure efficient drug procurement, supply chains, making sure the distribution is done well so that the drugs are not sitting in a warehouse somewhere, but it's reaching the facilities where our patients need it. And they need to enable multi-sectoral support for children and adolescents. So across different departments, how can we work together between Department of social development and justice and education? How can all these departments work together to improve the health of our children? So I think that's basically where I want to end. I think ending pediatric HIV or AIDS in South Africa is within reach. It won't be easy to do that by 2030. It will require coordinated action, urgency, commitments from all levels of the healthcare system, the clinician on the ground, the politician in his office, and everybody in between need to be committed to this. We know what works. We've got a lot of experience. We just need to apply the basics. We need to do the right thing every time, everywhere, for every child, and then we will see the results. So thank you very much. That was my overview of where we came from and where we are now. Thanks.
Awesome. I hope you can hear me. Dr. Christy, thank you so much. That was so empowering. Christy, can you confirm that you can hear me?
Yes, I can hear you.
Oh, okay. Perfect. 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 Yeah, I think you can stop sharing your slides there so that we can go through a couple of questions that people have. Yeah, colleagues, how was the first webinar of the year? I hope we have left you, or we are leaving you very, very, very inspired and looking forward to more. There is more I can tell you coming your way. Tomorrow we have the next webinar series. It will happen every single Wednesday this year. So if you are a primary healthcare nurse in the hospital, don't miss Wednesdays. And we do have as well our gynae series, and we are starting with gynae oncology, discussing some of the cancers and what you can do, and more and more and more and more and more. So we are so excited. Christy, there's a lot for you, but maybe let's start with Moses. I'm not sure whether the question he he wanted you to confirm that there's a decrease in HIV in children. Actually, when you go to your slides, I had a question to say, how do the pediatric wards, look like? Because when you see the decline, one wants to also see fewer kids, being admitted, or I don't know, not being diagnosed, etc. I don't know how is it going? What's your on the ground experience?
Yeah, no, for sure. think I remember when I was a student rotating through pediatrics, there were a lot of, if you walk through the peds ward, a lot of those children had HIV related complications. And these days they are still there, but there's a lot less of them. I think the pediatricians are in a better place maybe to comment on that. But I know just from doing walk rounds in hospitals here and there, and the calls we get from hospital doctors, there's definitely a lot less
Okay.
in these days compared to 10,
Awesome.
15 years ago.
Awesome. Edward was interested to look at how his district is performing. So I think we can actually ask some of the program managers to come and do the in-depth data presentation.
Some of the data is actually available online.
Yes.
If you search, I'm trying to remember what site now, because I saw some of it. There were definitely some of the sites I was looking at when I made the slides that had district level data. I think it's not always PED specific. Sometimes it's more for the whole program. But if you contact your program managers in your district where you are, they would definitely have the latest up to date for the previous quarter, basically. They would be able to give you an idea.
Awesome. I like that. Colleagues, just Google and see what you find, but we will make a plan, Siasanga says, is it because children rely on caregivers to take their treatment, or is it because they can't tolerate the medicine? It's a huge number of children who are not suppressed. So what's your top 2 reasons, Christy? I know it's complex.
It's very complex. I think there's more than 2 reasons. And Siasanga, it's both of those and more. The younger children do rely on their caregivers. A baby and a toddler can't take treatment for themselves. They need a caregiver who can understand how many tablets to give or how many milliliters of syrup. These days, it's easier with the disposable tablets. But they need to give it to them on time every day, not just some days, every day. And then as they get older, some children, maybe now they are 7, 8, 9, 10 years old. It's easy for the parent to say, it's time for your treatment. Go and take your tablet and swallow it. And the child will go there, he will take his tablet and he will decide today, I don't feel like it. And he will put it under his mattress or hide it in the garden or something. Because the caregiver is maybe not supervising the swallowing of the tablet. And then later on, they get pill fatigue. They just get tired of taking a tablet every day. Maybe they're not disclosed. They don't understand why they should be doing this. Or they understand, but they don't have that insight. Adolescents don't have the same insight as older adults. So they don't really see the long-term picture of how their health will progress or deteriorate if they don't take this tablet now today. They don't feel like it, so they don't want to do it. So yeah, it's complex. There's no 1 or 2 easy reasons. It's different for every child that you see. Oh, your sound is gone now, Lesego.
Because my daughter was here. I was saying, help David, what is VTP?
Sorry, I should have reminded us. So VTP is the new name for PMTCT. It stands for vertical transmission prevention.
Yeah.
So just instead of saying mother to child transmission, the mothers said they don't like being called out because it's not always their fault. So it's the same thing basically, but we just call it vertical transmission prevention. And I actually thought it was a South African thing. I thought we had made the decision in our country. But at some of these international conferences I attended and some webinars, I see even other countries are now talking of VTP. So
Okay.
I'm not sure if we learned from them or they learned from us, but it's becoming a global thing, which is quite nice.
No, we are trendsetters. I hope that it's ours. Yeah, I don't know. The schooling program and collaboration with them to respond to these challenges.
Yeah, I think they definitely learned some HIV related things in life orientation and some of their other subjects. In early years, I think some of the information that they were given was not always correct, and I'm sure there are some teachers who have better information and some teachers who are still hearing some of these myths. Sometimes they try to do the right thing, but they end up doing some harm. For example, we've had adolescents that told us when we ask them, what do you know about HIV? What did you learn in school? They will say things like, no, my teacher says we mustn't sleep around. We mustn't, at our young age, we mustn't sleep around because then you will get AIDS. And if you get AIDS, you will die. So you can see what the
The dying
teacher was
part.
trying to do.
Yeah.
They were trying to scare children from not becoming sexually active at an early age to protect them. But this child got HIV from his mother.
Aish.
He was born with it. Now, what he knows is if you get AIDS, you will die. Now, you tell this child, this treatment that you've been taking lifelong is actually ARVs. You have HIV. What does he think? My teacher says I will die.
No.
So, there are some challenges. Some teachers have better information than others. I'm not sure exactly what the school curriculum is. And then the school health nurses also have limited things that they can do. They can't really test children because of consent issues. So there are some challenges, but there are some opportunities as well to work with them to make sure teachers and children in the community in general get the correct information about what it is like living with HIV.
Awesome. Some Kelly was saying, so if the mother has a high viral load and we do give the dual prophylaxis, what can you expect risk-wise?
Yeah, I don't know if we have numbers really. I mean, the gold standard for the BTP program is getting the mom to be suppressed. That is our first strategy. And then the second strategy that's like our safety net is the infant prophylaxis. So we'll give AZT for 6 weeks and Nevirapine as long as she's breastfeeding with the high viral load. We don't extend the AZT too long, otherwise they become anemic. 6 weeks is okay, but after that it becomes a bit much. But yeah, we should, while we give the infant prophylaxis, we should be working on interventions with the mom to get her to be suppressed. I don't have a number. It's definitely not as high as it used to be, the 25 to 40%. It's definitely lower than that. But the higher the mom's viral load is, the higher the risk of transmission to the baby.
Awesome. Michelle is actually asking about how many of us colleagues are using the results for action. Are you receiving your results for positive PCRs and high viral loads? And are you responding to them? You can just share your comments in the chat. Give Dr. Michelle, she's a pediatrician herself. I know she likes supporting district hospitals. When I say results for action, does it sound like something you know? But at least all I'm asking is, do you automatically get abnormal results, and do you follow up to ensure that all those children are put on ARVs or those with high viral loads will respond? You can just help there. Omotunde, is it patients? These patients are declining. Preps in the clinic. What do we do? Your question is, I can't explain it properly. Are you able to make sense of it, Christy?
Yeah, I think they're asking, we are saying we must give PrEP, but in their experience, that patients are saying no, thank you. So how do we convince them
Oh,
to
the
take PrEP?
declining in terms of saying no. Okay.
Yeah, I think so. So
Okay.
that's a marketing strategy. I mean, we have to find ways. I think one of the common things that patients tend to say is, why should I take a once daily pill to prevent getting a condition that I will have to take a once daily pill for? You know, they don't really see the long-term benefit. So the messages that we need to get across is that PrEP is not a lifelong thing. PrEP is there for the time being when you are at risk. Maybe now you are young, maybe now you are enjoying yourself, you've got multiple partners or something. You are in a high risk period of life now. You might not be like that for your whole life. So you might be able to stop your PrEP if you end up being HIV negative and then continue a life without any treatment. Or if you, I mean, we say that people can have long healthy lives with HIV, and that is definitely true. But HIV still has other complications. You have these background inflammatory processes that's happening, and you will always have the potential of drug interactions that you won't be able to get away from. So I think it's just putting things in perspective for them. We are not just thinking of the next few months or, you know, the next couple of years. We are thinking of the rest of your life until you are 80 or 90 years old. So that's why we want to keep you negative now so that later in your life you don't have to worry about HIV or about ARVs. I think those clinicians who have found strategies to convince tricky clients, you know, that marketing kind of thing, can also share their strategies in the comments so that all of us can learn from them. Yeah.
Awesome. Moses says, okay, where is the injection? Do we even have are we preparing for pilots or for rollout, Christy, or we do have some pilots
For PrEP,
already?
yeah, the PrEP pilots are starting. I think they are planning to start from April. I'm not
Okay.
exactly sure, but it's soonish. The trainings are busy happening now, so that's the PrEP injections. The pilot sites have been identified. It's not in all the provinces, but there's, I think, I'm going to lie if I give you numbers now, but there's a few provinces that were identified, and each of them identified a few facilities. So those will be the pilot sites, and then later on it will be expanded, hopefully, to the rest of the country as well. I'm not sure exactly what the timelines are like. And then the treatment injection we don't have available as far as I know. If
Yeah,
people
not
from the
yet.
private sector can correct me if I'm wrong, but I don't
Coming
think we have
soon.
that available. Coming hopefully
Coming
soon.
soon. Yeah, that will be a big game changer. This one I'll respond. Norma, regarding the slides, like I said, we are a membership-based platform. Members do know that they will get access to the recordings and stuff. Slides are always the intellectual property of the presenter. We will check and we will let you know if we are able to disseminate. Actually sharing a link. Those of you who are interested in membership and you have a lot of questions that you would love us to respond to, click on that link, share your information. The team will contact you and they will be able to help you so that you can ask all the questions and we are able to help you. Lulama says it would be good if our doctors can be part of this platform. They are here. How? I'm here. Or the one you work with, Lulama. You must invite him. You must invite him if him or she, if she's not here, just invite him. But we are here. We are here. But I guess not everyone is here, you know. So we are still experiencing babies taking bloods for HIV testing before 18 months using, drawing blood instead of dried blood spots, giving incorrect and false positive. I don't know about false positive, etc. EDT is which one? Is it the purple one? I don't know. Christy?
Yeah.
I would rather
No,
maybe say ELISA versus
I
DBS.
think they mean ELISA
Yeah,
testing. Yeah,
yeah,
because EDT is the purple top tube, so they probably send that. So if
yeah.
they send it for a PCR, that's okay. It's more expensive than a dried blood spot. Um, but it won't be inaccurate. If they send it for ELISAs, though, which I think is a yellow top tube, not an EDT
It
tube,
should be
EDTA
yellow.
tube, that might give you false positives if we then pick up the mom's antibodies. So it depends which test they are doing exactly. But you're right, the guideline does say we should do dried blood spot testing up to 18 months, not necessarily tubes.
Thank you so much, Christy. I see questions about CPDs and certificates. As you know, the platform is like 4 years old now. We do allow people to join events, but CPD certificates, a lot of administrative. We're actually in the process of renewing the accreditation for that, and I tell you, they are not playing, the councils. So yeah, do join and support the platform. The most important thing we want you to achieve is to go and improve the care for children. If you want something a little bit more, I'm sharing that link again. Do make an effort, click on it, put in your details, ask the team to contact you, and they will contact you. You'll ask all the questions. You can also, Kuli, you are here. So Kuli is the national manager for the VTP PMTCT old program. And I see a comment, our clinicians still need to be equipped about managing patients on PrEP. Okay, so the monitoring of patients on PrEP. PrEP is the same as TPT. We need to come up with strategies. Where is the injection? Oh, I saw TPT. Christy, we used to have a lot of discussions. I think 1 or 2 sessions where we spoke about TPT in pregnancy. Did you see the U10?
Yeah, there's new circulars flying again.
Funny
So,
enough, when I saw the U10, I just thought of the discussion I had with you. I was like, can this really be applied like for all pregnant women like zilch? I just didn't really support it. But anyway, a wise man always reviews. Mistakes. There's nothing wrong with mistakes. There's a problem if you don't appreciate the changes you want to make. And I think the current one is a bit better. They've considered some women who are eligible. So I think I'm happier with that one. Yeah. So colleagues, I think for tonight that's it. It's exactly just 3 minutes before 8. Dr. Christie, forgot to tell you that I've been appointed as the president of the country, and I'm so happy to appoint you as my Minister of Health. Yay! You know what?
Patrick Health.
You know what is the
I'm
challenge you
not a
have?
pediatric.
Is that in the next 30 days or in the next, I don't know, few years, yeah, I need 0 babies born with HIV, and I'm giving you, as my minister, that goal. Is there something that you think you would? I mean, we showed that slide with many guidelines, and it's like we are doing. If you had a chance and there was no limits in money or whatever, but you had a chance to make transformation, what would you? I mean, what more can we do? That's what we are trying to get to. Yeah.
Well, if it's about money, I think we can bring in some of those nice long-acting ARVs. But even without money, if we all just do the basics right,
Yeah.
we can make such a big difference. I was talking with a colleague last week. She was on her way to a facility to go and do a quality audit of something. And I said to her, you know what? If everybody just did all the basics right,
Mm,
the OPMs wouldn't even need to be doing file audits. And
mm,
you wouldn't have to go there to check if the OPMs is doing the file audits to pick up the gaps.
mm,
Everybody just needs to do the basics,
mm,
so that we don't need money for. We already in the facilities,
mm,
we already have the patients in front of us. We have the
mm,
guidelines.
mm,
Just need to engage with them to make sure we understand them. And if you have questions, there's helplines and there's there's referral hospitals with helpful doctors. Ask,
mm.
ask advice and you will receive.
It's very interesting. You gave your president a problem that is very complex. It's more complex than giving injections, isn't it? Getting people to do the right thing consistently, but there's also the patient side or the community side, which can add to the complexity. So it sounds like there's a lot of, I don't know, I don't want to say behavioral kind of thing but on both sides, the supply and the receiving side. There's just one question which I think I would like you to respond to before we close, because I think it's important. The issue of indeterminate PCRs, fail services. Can I give ARVs on a child who's got an indeterminate? Because this is quite common. It's a common question. Gugu, sizokhuluma sivala ngalene. Gugu Malinga, apologies. This will be our last question for the night. Apologies. Yes, Christy?
Yeah, so if it is the first non-negative PCR, so if it's a birth PCR that's indeterminate or maybe a later PCR, but the previous PCRs were negative, then we don't start ART immediately. We repeat it first. We know an indeterminate PCR is quite likely to be positive on repeat, so we really have to repeat it. If we have 2 indeterminates, then we can start ART.
Okay.
Or if we repeat it and it's positive, or if we do a viral load and the viral load is detectable, then we can start. But with a positive, we initiate after the first positive while we do the confirmatories. For an indeterminate, we have a high index of suspicion, but we don't initiate immediately. We do urgent repeat testing. And yeah, if we have a follow-up test that is also confirmatory or suspicious, then we can initiate the child. If you have any questions, phone one of the helplines, hotlines. There's always people willing to assist you with your diagnostic dilemma. That's what we call them. If we're not sure what the child's status is, even after testing them.
Awesome, colleagues. Just to say thank you so much for joining us this evening. We really want to appreciate you. These sessions are not enjoyable without you. Otherwise, it will be me and Christy just talking our own things. So we really want to appreciate you for that. Dr. Christy, as always, thank you so much for making time and for preparing. It does seem like the year is starting. We may need to I don't know, have a proper program, and maybe VTP, we need to do it again. You can see with some of the questions that we didn't even manage to go through. So yeah, at least guys, you are giving us a sign on some of the issues that we need to look at. So just to appreciate you, all of you, remember, if you are interested to support and grow with this platform, just complete your details there and we will give you feedback. On that note, Dr. Christy, sharp. Night, colleagues. Blessings. Bye.
Thanks, everyone. Bye.
Bye.
Welcome to Seminars in HIV Care. Tonight, we focus on one of the most critical journeys in modern medicine, pediatric HIV care. From the challenges of the past to the breakthroughs shaping today and the possibilities defining our future. This session brings a full circle view of how far we've come and how far we can still go in protecting children from HIV. Thank you for joining us. Let's learn, reflect, and envision a healthier generation together.